Thank you very much. So I'm the propaganda guy, and I'm different to the two prior speakers in that I work in a district general hospital, and what that means is that I have to approach things slightly differently, because I don't know about Professor Singer's hospital, but at 8 o'clock on a Tuesday evening, my world is not populated by mini Mervyns who give consideration, who are able to stay with the patient, who are able to intervene, consider the response, and plan further action. My world is populated by specialist nurses, by junior doctors who are often average, who are often locums, who are often hungover, and they're more interested in when they're going to go home or how attractive the new staff nurse is than some of the care they're delivering to the patients. Moreover, they're stretched. They may be able to give a patient 20 minutes of their time at one time point, but they won't be able to return to that patient for another couple of hours. So in my world, I have to be slightly less considered and slightly more didactic. So I am going to share in outline detail, because I'm not allowed to share in detail at present, some of the outcomes from the NCPOD study, which will be published in early November, and it will be confrontational. It will be big. We've got evidence arising from examination of what happened to somewhere around 1,000 patients in the UK. And that leads me with some authority to be able to tell you what's happening today. Well, what's happening today, and I apologise that the picture's grainy, there are no more recent photographs of Jem because this was taken in 2005 and he died 2 weeks after this photograph was taken. But what the propaganda guy in me would tell you is that what's happening today is 100 people like Jem are dying and 200 people like Jem are surviving. Of course, that's not strictly true. About 10 people like Jem are dying today, and about 90 people over the age of 65 are dying from sepsis today. But it's a nice media story. The other point about Jem is that Jem, like approximately 3/4 of patients who subsequently developed sepsis, contracted his infection leading to sepsis in the community. And so when I talk about giving antibiotics within 1 hour, and I fully agree with Mervyn's sensitivities around the quality of the evidence behind that, and about the concerns and the very real concerns about the need for antimicrobial stewardship. And when Mervyn offers a slightly more considered response that we shouldn't delay excessively when we're convinced patients need antibiotics, and we certainly should try to treat within 4 hours or so, but we need to make sure we make the right choice, we have to consider people like Jem in this mix. Because if 3/4 of patients are developing sepsis outside hospital, and like Jem, progressively deteriorate with little monitoring, monitoring doesn't exist in the community. Many general practitioners will not measure blood pressure unless it's part of a QOF target. Paramedics might come to assess Jem. 111 might receive a phone call from Karen to describe some of his symptoms, and they often don't fit into the nice little boxes, and often monitoring and measurements are not taken. So how do we identify when badness occurs in Jem? Well, badness was certainly present when Jem arrived in my emergency department because he suffered a cardiac arrest within 10 minutes of arrival. So clearly the opportunity to intervene was prior to that, but we don't know when. Was Jem demonstrating altered mentation? Well, yes, he was. He was dysarthric, he was confused, he was delirious at times. Was he demonstrating hypotension? Well, we don't know because nobody measured it. Karen describes that his fingers looked a bit of a funny colour and his lips looked a bit of a funny colour, but of course no one measured his blood pressure. And we know, because fairly low quality evidence shows us that respiratory rate measured outside hospital is fairly unreliable, but of course again nobody measured it. So from the first signs of or symptoms rather of infection, Jem spent 52 hours in the community before he had a cardiac arrest in my emergency department. So for me to talk about giving antibiotics in 1 hour, and for others to talk about giving antibiotics in a more considered and robust fashion in a slightly longer time frame is all a bit artificial, because we don't know when Jem needed his antibiotics. And we've talked about heterogeneity with sepsis, and of course we're putting Jem into the same pot as someone with comorbidities in their 80th year who've developed sepsis following a surgical insult and been recognised quickly. And we're examining them and treating them in the same way. So I absolutely agree with everything Mervyn says. To say one size fits all is incredibly flawed, because it doesn't. But in my world, in the GGH, we have to adopt a slightly pragmatic view. And I think we need to step outside this idea that sepsis is about hospitals. Because of the 3/4 of patients who contracted their sepsis or contracted their infections in the community, 60% had sepsis on arrival to hospital. So about a half of our population with sepsis that was submitted to this study had sepsis at the front door of the hospital. So we need to look beyond the hospital to find out when time zero actually is. This is Villa Park, and hopefully next year it will be full again. You won't see it full at the moment, but when it's full, it holds about 38,000 people. And that's about how many people are dying from sepsis every year we anticipate. So the North Stand there is about 8,000 people. That's how many people are dying of breast cancer each year. Trinity Road Stand's about 14,000 people, which give or take is approximately bowel cancer. Apologies for the formatting from the Mac. And I've just said that sepsis we conservatively estimate to claim about 37,000 lives in the UK. Now we have to concede here that sepsis is a syndromic response. So many of these patients, we know from the National Early Emergency Laparotomy Audit that probably about 4,000 patients are dying as a result of emergency bowel resection surgery. And many of these deaths will be included in that group. Some of these patients will have had neutropenic sepsis following chemotherapy for breast cancer. And of course, there's a lot of crossover. But these data are probably fairly conservative if we look at some of the international data, which I'll show you in a moment. And these are from the NCPOD report. And of course, there's the bias in observer presentation. Most cases in the NCPOD report were presented by members of critical care outreach teams. But it's interesting to note that we seem to have a slight preponderance of urinary tract infection in the UK as a causative infection for sepsis, which is rather higher than we've seen in some of the European studies. And we seem to have rather lower numbers of intra-abdominal sepsis as a causative infection for sepsis than we've seen in some of the European studies. So that's interesting and worth bearing in mind, particularly in the context of some of the recommendations coming out of the National Early Emergency Laparotomy Audit. I'm obsessed with early. And I said it might be an underestimate, and this isn't a particularly pretty slide, but the estimate at the bottom, which is the one I've given you, is based on an incidence of 150 cases per 100,000 population per year. And there are other studies out there, and you can read the figures for yourselves, but I think it's interesting and to a certain extent validating that the shapes looking at community-acquired mortality, proportion of survivors, overall mortality compared to the number of cases are similar in each of the studies. So we suspect that the incidence is somewhere between 150 and 466 is probably a bit high, but somewhere between 150 and about 350 or 400 cases per 100,000 population per year. Now, what Matanada Kim and I did was to look at some of the existing data that we can collect in the UK easily from Dr. Foster, from the HSCIC, and from HES data. And we're not suggesting that there are 900 cases occurring per 100,000 population per year, but this is the potential screening population. It might be about 900 patients because we looked at the ICD-10 codes, we excluded codes like pancreatitis that weren't necessarily compatible with infection, and we included infectious diagnoses, and then looked at the mortality of that group, and it was similar to the mortality rates in other studies. So we might be looking at a screening population of about 900 patients per 100,000, of whom perhaps 1 in 3, perhaps 1 in 6 might require some form of intervention. And it may well be that and I absolutely welcome that we're about to have an alternative form of definition of sepsis, and it may well be that that brings out who we need to treat from that screening population. We think sepsis is getting more common. Data from the Centre for Disease Control suggests it's rising at a rate of between 8 and 13% per year over the last decade. Is that because we're spotting it more frequently? Probably. Is that because it's occurring more frequently? Possibly. We simply don't know. The proportion of presentations to critical care, and this is from Intensive Care National Audit and Research Centre, is similar. But the numbers are greater, suggesting, and we know that we're seeing more and more patients coming through critical care. Of course, during this time period, over a couple of years, more intensive care units are submitting high dependency unit patient data to the database, and more are reporting to ICNARC from the outset. So we don't know whether this is genuinely increasing in numbers or whether we're simply seeing more patients coming through and being recognised. But it's certainly a big problem. And we've talked about sepsis from a binary perspective. We've talked about sepsis as survival or death. But we need to stop thinking about sepsis in terms of survival or death, because what we do early, what we can do with our early recognition, might impact upon long-term outcomes. Now, some sepsis survivors will go on to relatively normal lifestyles, normal for certain individuals. But others aren't so lucky. And we think from the literature that we have an incidence of somewhere between about 17% in terms of cognitive impairment following intensive care admissions with sepsis, and 22% incidence of post-traumatic stress disorder in other areas of the literature. And in fact, the NCPOD data will seem to bear this out, that we seem to have about a fifth of patients who survive sepsis who have long-term problems, morbidity at hospital discharge, morbidity at 1 year, if we're looking to the literature. And we don't offer rehabilitation services to these patients, we just throw them back. And I know, and it's anecdote, from the 500 survivors who currently interact with my charity, that the average time for those who did return to work was 1 year. So the fiscal burden of sepsis, we talked to the politicians about a bed day burden, a cost in terms of bed days of £2.5 billion per year, based on the SOAP study from Europe, which suggested that each episode costs about €25,000. But the fiscal burden is significantly greater than that and is not measured. So we need to stop thinking about sepsis as a binary thing, and we need to start examining, I believe, whether early intervention reduces long-term morbidity. Logic would suggest that it would. So I'm all about fixing the system. And what we don't need is to fix the system for patients like this, patients with purpura fulminans, patients with overt shock, because any junior doctor, however average or below average they might be, should recognise a patient like this who's deteriorating. So I fully agree with Mermit. We need to identify badness, but before it gets to this stage. There is no point and no use in having a scoring system that will identify these patients, because we're unlikely to see further improvements in outcome. And this has already been alluded to, and again, apologies for the formatting at the bottom there, but we assume that this is a continuum, and of course it's not, and Mervyn's covered this. But if we look at the mortality rates at the top, we start with infection. Mortality rate is certainly lower than 1%. Sepsis, some cohort studies suggest that if you use SIRS plus infection as a definition, then that cohort has a mortality of around 10%. Severe sepsis is not now 35%. ICNARC data suggests it's now 28% in the UK. And septic shock still is very high at about 50%, or even higher from the ICNARC data at about 52%. So this leads us to try to identify when we should intervene. And it presented us with a problem, because these were some of the international consensus definitions for organ dysfunction. So by international consensus definitions and by Surviving Sepsis Campaign guidelines taken at rote, one would have to identify the SIRS criteria, which we've agreed are extremely poor, plus a clinical suspicion of infection, plus identify one or more organ dysfunctions. Now, most hospitals like mine acknowledge that we didn't identify any of this stuff because my patients get one opportunity with the doctor, and that doctor might send some blood tests off, but they're not going to return an hour and a half later and re-examine the patient with those blood tests on a stretched ward or in a stretched emergency department. So what we were finding is that we were identifying and treating these patients, the patients with organ dysfunction criteria that we identified at the bedside, but not those in whom we relied on laboratory-based definitions. And what that led to was a dichotomy where some hospitals were going by the book and some hospitals were waiting until organ dysfunction was definitely present in order to intervene. And some hospitals were making the assumption that the continuum was true and that they weren't going to wait until organ dysfunction ensued, and they were going to intervene at the stage of severe sepsis. So they were giving broad-spectrum antibiotics when the patient had the systemic inflammatory response syndrome plus an infection. And clearly, that's bad. That's wrong. And we couldn't tolerate that. And that's why in the UK we came up with this concept of red flag sepsis, which I am absolutely prepared to modify and change and perhaps ditch when the new consensus definitions come out. But I need to be adequately reassured that it's applicable in the community as well as in hospital. Because what GEM's GP, what GEM's paramedic, what the ambulance controller wanted to know was not whether GEM needed to go to intensive care for 3 days or more or was going to die, but whether he needed to go to hospital or not, whether he needed intravenous antibiotics and some monitoring that couldn't be offered in the community. Now, anecdote again. I'm the propaganda guy, so I'm good with anecdotes. But this chap didn't have altered mentation, hypotension, or tachypnea when he arrived in my emergency department. This gentleman didn't trigger on the National Early Warning Score. This gentleman probably would have bypassed the emergency department, ended up on an inpatient ward, and not had any further observations for another 4 hours, and not been reviewed by a consultant for 16 hours, had we not had a policy that every patient who was triaged through to a majors cubicle had a capillary lactate measured. And his lactate was 8, which to many intensivists, and again I agree, who could challenge that lactate is not a bad guy, lactate is necessary, and in critical illness, reducing the lactate may not actually be such a good thing, although it seems to predict positive outcome, because in critical illness, the heart sometimes relies on lactate as a substrate for adequate contractility. But this chap had a high lactate, and it was flagged up to us, and we went down. And we know that high lactate predicts adverse outcome. We also know that there is this entity that's been termed by the Americans cryptic shock. And that's defined as a normotensive patient, as this chap was. He wasn't normotensive for a 78-year-old, perhaps, but he was normotensive according to news, and it's news that our junior doctors are using to identify critical illness. But we know from various studies that if the patient's normotensive but their lactate's high, which the Americans will call cryptic shock and which seems to occur in about 1 in 4 cases of patients who are normotensive, that the outcome for non-shock high lactate patients is identical in terms of mortality than for patients with overt shock and a high lactate. So it does seem to be a marker of badness, and there is a question raised as to whether with the new definitions there might be some clinical areas that might need some additional markers. And we've already heard that for every hour we delay in administering antibiotics in septic shock, mortality increases by 7.6%. And I concur that we shouldn't draw a level 1 recommendation from this study. It was retrospective, it was over 15 years, and actually only about 300 patients received the magic antibiotic within the magic first hour. But there are some prospective observational studies, and I'd agree with the first speaker that it is highly unlikely that we're going to do a randomized controlled trial on whether to give an antibiotic or not. So observational data might be the best we get. I've mentioned the NELA, and I'd just like to throw out there thinking about what happens. I've told you that about 11% of patients presenting with sepsis to the NC-POD study had intra-abdominal infection. And we have recommendations arising that suggest that some hospitals are doing quite well with emergency laparotomy and some hospitals are doing relatively poorly. Now, my hospital has a 24-hour emergency theatre, and the focus is on the emergency laparotomy, and that's absolutely correct. But we just have to think about what's happening through that focus on emergency laparotomy. I'll tell you what happens in my hospital. If someone's on a ward with presumed septic arthritis, they cannot get into the emergency theatre because the laparotomies are prioritised. And in fact, to get any orthopaedic case into the emergency theatre is an incredible challenge in my hospital. We don't have 24/7 trauma theatres. So we have to think about the knock-on effects of prioritising one particular condition over another. Now, I anaesthetise for colorectal surgery, I'm involved in the emergency theatre, and I'm not trying to say we shouldn't prioritise emergency laparotomies, but more common appear to be Urinary tract infections. Are we getting ureteric stents in time for people, for example, with obstructive pyelonephritis? Are we getting the people with skin and soft tissue infections debrided or washed out in time? We need to ensure that all patients with sepsis have their source control in a timely fashion. Now, again, formatting errors, but I wanted to talk about the Sepsis Six, and I've acknowledged that there are flaws. This is didactic, and any good pathway that includes the Sepsis Six will include variance boxes. And I concur with Mervyn that high-flow oxygen is probably harmful in these patients, and we've got an NIHR-funded study going on in 3 emergency departments at the moment as to whether hyperoxia or normoxia or relative hyperoxia seems to be the best thing to do for these patients. But people seem to like the Sepsis Six. Again, in information that's relatively vague from the NCPOD study, more than 90% of hospitals in England, Wales and Northern Ireland are using the Sepsis Six protocol. So it obviously ticks some boxes and is liked by some individuals. And it seems to be associated, where it's been examined, again just in prospective observational studies, with improved outcome. This was ours. This was a low-level improvement project. We trained some nurses up. We sent them out onto the wards for eight months, and we examined what was happening. And their compliance with these care bundles went up, and mortality appeared to fall. And you'll note I've put number needed to treat in brackets, because this wasn't a randomized control study by any stretch. But the groups were similar for age, for comorbidity, for presentation, for acuity of illness, etc., etc. They were also similar for time and day of presentation to hospital. And it is interesting to note, and it's probably just a surrogate measure of better care generally, that patients who received the Sepsis Six had a 20% associated mortality, and those that didn't had 44%. And this has since been replicated with varying degrees of cohesion in many hospitals up and down the country and outside the country. And if we believe that it's the Sepsis Six, and I'm not suggesting we should, then it's an intervention that we need to do 4 or 5 times in order to save 1 additional life. Now, I put this up in the interests of transparency because this is my hospital's ICNARC data for severe sepsis. This is my intensive care unit's hospital mortality for sepsis. And within the UK, Scotland nationally now have a mortality for sepsis of 19.9%. Some of the best centres in the world have mortality just about in the single figures, so we can't save everybody. But we like to think in the UK that if we've got mortality stable down at about 20%, we're not doing a terrible job. And I put this up just to show that, even though I champion in this, we're not always getting it right. Now, these are small numbers, so a tiny blip, 1 unpredicted death, can cause your figures to go askew. But I like to think that there seems to be a trend there that we're slightly better than national average. And we're not doing anything special. We're just identifying patients early, and when they're needing critical care, treating them in an almost identical fashion to that just described by Mervyn. Now, I've mentioned that if we get the basics right, we might be able to reduce long-term complications, and we have some evidence that getting the basics right does indeed prevent patients going to critical care. And this was a study from across 11 hospitals in North America, and they were looking at a form of early goal-directed therapy. And it's interesting that you've had sort of 3 experts in sepsis talk to you, and 1 has not alluded to early goal-directed therapy, and 2, including me, have only alluded to it because we are so sceptical of it. But the reason this study was interesting is that by doing the basics right, and they allowed 3 hours for the basic care bundle, patients became ineligible for the remainder of the study. So they couldn't examine the effect of central venous catheters and targeted pressures and inotropes and vasopressors. We would like to think that emergency departments get this right, and we've done 2 national audits now against these standards. We wanted 50% of cases to receive their antibiotics within 1 hour and 100% within 4 hours prior to leaving the emergency department. And this is for patients with severe sepsis and septic shock according to Sepsis version 2.0. We've audited it twice since. In 2011-2012, 27% of patients in emergency departments were receiving first-hour antibiotics, and in 2013-14, this had risen to just 31%. So we've got a big challenge and a big problem ahead of us. We can save people. This guy did have badness, and his badness was identified by his high lactate, and I have no financial interest in any point-of-care lactate measurement company. But his badness was identified by his high lactate. He did need to come to critical care. He did need some vasopressor support because he was profoundly hypotensive, and after a couple of hours his urine output started to drop off and his blood pressure started to fall. But he was adequately resuscitated with cautious fluid challenges, and this was him 2 days later having improved, and he went home relatively quickly. It's anecdote, but what would have happened to him if we'd waited for 24 hours before intervening? We simply don't know. So mindful of all of this, and mindful of the challenges we've got in terms of the healthcare system in identifying sepsis, and it really is this recognition that's the key. The treatment we can talk about later, but until we're recognising people in the community, about 1 in 6 of the people who develop sepsis in the community and present to hospital are in residential care facilities and nursing homes, so we need to understand what's going on in those environments as well. We've developed a series of resources, some clinical toolkits, some screening tools based on red flag sepsis, and we signposted to them via NHS England. This is just one version. Now, what we'd had a problem with was this issue where some hospitals were treating sepsis, some hospitals were waiting for severe sepsis, and they were really only identifying those patients with the red flags, the organ dysfunction criteria that we could measure at the bedside. And we thought that wasn't good enough. So we looked to develop some other red flags. And again, these will be modified over time. These are currently being examined at King's College Hospital and a couple of other emergency departments to determine whether these are valid or not. Because there's no high science behind these red flags. They're just news criteria from the National Early Warning Score. So we've got these arbitrary cut-offs of systolic blood pressure, of heart rate, of respiratory rate, of oxygen saturations, the latter 3 of which are taken directly from the news score. They're parameters which have an individual score of 3 or more and should trigger a response in hospitals using news. It seems to have been relatively well accepted because it's pragmatic. And although there's no science behind it, the intent is that it does improve antimicrobial stewardship because it stops those hospitals giving antibiotics for SIRS plus sepsis and identifies people who, by anyone's count, and we can argue about the respiratory rate, which might be a little bit low, but by anyone's count, represent a physiologically probably sick cohort of patients. So it's a pragmatic intervention and one which will change over time. These are likely to be, although we don't know the thresholds yet, the Q-SOFA scores. And I think we have to consider what we can do with these in the community. We have to consider what the public message is, what the GP message of these is. Can GPs start measuring respiratory rate? Well, we don't know. There are studies that suggest that they don't measure it very well. Can we train them to better do it? Can we persuade GPs to measure blood pressure in patients? Again, we don't know. Does blood pressure in the community add value over assessment of skin temperature or skin colour? Again, we don't know. Augmentation is probably slightly easier to communicate. But again, are there other red flags which are relevant in making decisions about whether to transport people to hospital or not? Is there a role for point-of-care testing? Point-of-care lactates, point-of-care differential white cell counts in the back of ambulances, in the GP surgery, in the emergency department. Some of these devices, like the white blood cell one there, doesn't need calibrating. There's no quality control needed. It's optical, it's sealed, it goes back to the manufacturer once a year to be recalibrated, and it's relatively inexpensive. Can it help with decision prompts? Can it help with the decision whether to transfer the patient or not? I believe that we need to get to a system where we have a seamless response, where members of the public are looking for sepsis, they're aware of sepsis, and they're saying, I'm worried this might be sepsis. And that we don't jump in with the Sepsis Six, but we qualify it, we understand it, and where necessary, we get the patients to hospital. So we've worked with multiple agencies to do this, and these are some of the last slides, but we've worked with the ambulance services so that sepsis is now a time-critical condition, so that ambulance services, paramedics will now screen for sepsis and pre-alert. We've worked with Pathways who make the decision prompts for 111 to make sure that they're pathways. I've spent 8 hours looking at pathways on a computer with people, trying to understand where we might be missing patients. We're working with Public Health England to pilot public awareness schemes. And these are not television adverts. These are just pharmacists and GPs giving out some safety netting cards, highlighting some basic lay language symptoms that people should look out for. If they're being prescribed amoxicillin or told they've got a viral infection, just look out for these things. So this is being piloted in Lancashire and other areas at the moment. And we're measuring unintended consequence. And the last thing I want to say is about the sequin, about the politics. So the Secretary of State for Health has now taken an interest in this. He announced on New Year's Day a raft of measures, of which the one that's going to most directly affect the people in this room is the national sequin. And I would just like to reassure people about the national sequin. The intent is not to make sure that emergency departments give antibiotics to everyone as soon as they walk through the door in order to game and hit the target. And that's why we asked Part 1 to run for 6 months. And remember, the sequin is optional. You don't have to do it. You just might get a bit more money if you do. But Part 1 is about screening. So no money in the first 6 months will exchange hands for giving a single dose of antibiotic. We need to make sure that organisations get screening better. And again, there's opportunity to modify the methodology of screening over time. And of course, any sequin can be modified locally in consultation with the CCG. Part 2 is about antibiotics, but to get the money for Part 2, they've still got to do the screening right. So they've still got to demonstrate red flag sepsis, severe sepsis, septic shock, or with version 3.0, sepsis will do fine. And we're only asking, because there has to be some understanding that not every patient requires antibiotics immediately. There are the pancreatitides, there are the gastroenteritides, that we need some more time to make the decision, that the maximum money is available with just 80% compliance with first-hour antibiotics. And just to finish, just to remind us what getting sepsis might look like if we get it right. It might save about 12,500 lives every year, which of course is as many as if we stop people dying of bowel cancer. Now, the data from Scotland corroborates this absolutely, because their baseline mortality is 32%, they've now reduced it to 20%, and that corroborates exactly with the equivalent across the United Kingdom of saving 12,500 lives a year. So we suggest it's doable. Thank you very much.